The recording is for the last year, and it has a different chapter number, but the title is the same. They didn't do anything with this new edition as far as update information, really, except for when they're talking about perio and the AAP classification, because that changed in 2017. But aside from that, all they did was mix up the chapters to really confuse people like me, as you know how confusing it was last semester. So we've got less chapters to go through. We are going through the process of care this semester and last semester. I'm going to take myself off camera here too, because I can't stand seeing myself. So we're going through the process of care, and this is another section of the book, the dental hygiene diagnosis and care planning. So what have we already gone over? What was last semester?
Assessment.
There you go, assessment. Yeah, we did the assessment. So we're going over ADPIDE. And ADPIDE is going to be haunting you for the rest of your career. These are the steps in the process of care. We have done the assessment, so we have done all the data collection. Now what we have to do is identify the problems based on the assessment data. You have done the medical history, you have done the vital signs, you've done the EOIO, you've done the caries risk assessment, you've done the perio assessment as well as the hard tissue. So this is going to drive what you're doing for your patient. So now we're into the diagnosis portion of the process of care, and that's to identify the problems based on the assessment data. So we are creatures of habit. Our process of care, our dental hygiene appointment has the same steps in it for everybody, but we individualize steps within everything that we have to do, depending on what our data collection stands for. So we're going to be going over diagnosis. Then planning is selecting, prioritizing, and sequencing your dental hygiene interventions. That's your treatment plan. Then you're going to implement the plan. And did everything work or not? That's your evaluation. Did it work or did it not work? And if it didn't work, what alterations do you have to do? And at the end of everything is always document, 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 because if it's not written down, it never happened. So we're individualizing this process of care, and these are all the steps in the process of care. So when we are talking process of care, these are the steps, the ADPIDE, trying to maintain optimal oral health as well as bring the patient back to optimal oral health, depending on what their status is. So we've got the process of care, and it is a formal dental hygiene care plan. So all the dental hygienists in America know this process of care. And part of that is not only to identify the dental hygiene interventions, but we're going to be educating the patient as well, depending on what that data collection, the assessment collection was that we had. Are they more caries prone? What is their gum disease status in their mouth? What is their, we call it dental IQ, which is really not politically correct, but what is their knowledge of dental and how it affects them with that oral systemic health? We need to make sure that we have secured informed consent, that is the patient signing the treatment plan, and communicate our planned interventions. Through that, we have some ethical applications, and these are the basic concepts of healthcare law that are going to apply to us as dental hygiene professionals. So the Dental Hygiene Practice Acts of each state, okay, tell us what we can and can't do for our licensing. And we are in a tri-state area, DC, Maryland, and Virginia. We each have our own practice act. So in DC, you can you can give local anesthesia. You can use the laser. They were the first ones to do that. Then in Virginia, we could give local anesthesia and we could use the laser. In Maryland, you can't use the laser. You can give local anesthetic, but you can't give blocks. So you need to know what your individual state is allowing you to do, because you can really get stuck in doing some unethical things unknowns to you. I think I told you when I was a dental assistant, I was working in a pedo office and they were having me hook up the nitrous oxide and scale teeth. And I was going, okay. They showed me what to do and I was doing it. I didn't know that I was working outside of my scope of practice. Dental assistants still to this day are not allowed to put nitrous oxide, hook it up on a patient. They can put the mask on, but they can't do anything with the knobs or the gases, nor are they allowed to pick up a scaler, really. Do they do it? Oh, yes. Orthodontic offices, those assistants are using the ultrasonic, they're using the Prophy jet, they're doing everything. Is it legal for them to do? No. So we want you to be well informed. So our practice acts are the ones that govern what we can and can't do. And you'll be getting more into this in your ethics and jurisprudence course, which is one of your capstone courses your last semester. It's a 1-credit course. I have been president of the state association, and we spend a lot of time as a professional association trying to guard our education and not have it devalued. So there has been some fights over the years with the dental association and organized dentistry too. You know, what can assistants do and what can assistants not do? What can hygienists do? What can hygienists not do? What education is required for each and every part of these procedures? Dental assistants could give fluoride to patients before dental hygienists could, because it was in our practice act that we couldn't use Schedule 4 drugs, and fluoride is considered part of that schedule. So we were administering fluoride treatments to our patients illegally for so many years. And that was one of the big fights when I was president, that and continuing education for relicensure. But anyway, you are part of your dental team, and it's important that all the members of the dental or health team work together. There is something called intercollaborative treatment now, where it's not just you working in the dental office. Intercollaboration is you are able to call a physician, say they're on a calcium channel blocker, and you don't know about this yet, but that increases gingival enlargement. And this patient is having a severe reaction to this medication. Then you or your doctor, depending on what office you're working in, can call the physician and say, look, this is what we're finding. Is there an alternative medication that might work better? Okay, where these side effects aren't having for this particular patient. So that's the intercollaboration. Are you contacting certain physicians to see if your patient needs to be pre-medicated? What blood work do you need if they're HIV/AIDS? Do you need that CDT4 count? And do you need an INR because they're on a blood thinner with this medication or without that medication? So that's why it's so important that you know exactly what medications the patients are taking and the dental ramifications. So for each and every patient, you're going to be having drug cards. These drug cards are going to be pulled out and used just for that particular patient. And then you're going to file them away because you might need it for the next patient. And then when the other patient comes in, you're going to pull them out again. There have been questions about the drug cards. Can you purchase drug cards? Yes, you can. These drug cards are not all inclusive, so you still need to be able to know how to look up lexicon. We need to know what that dental implication might be. Is it dry mouth? Is it orthostatic hypotension? What is the dental implication? Does it increase bleeding? And you can just write directly on the cards for that. But a number of students have purchased the nursing cards.
Let me see.
Yeah.
If we buy the cards, and when we have a skill eval, we can just show that to the professor.
Absolutely.
Okay.
Absolutely.
Okay.
But make sure that there's a dental consideration in there. And that's where the nursing cards might not have. Now, they might talk about dry mouth, orthostatic hypotension, and other things, but you'll have to go through and highlight them.
Okay, thank you.
Okay, so and it's by pulling these cards and actually reading these cards that you are going to know the pharmacology that your patients are going to be on, because there's so many medications and you're not going to be allowed, don't have the brain space to know everything and all the changes that come out every day. And that's one of the beauties of the LexiComp site over having a printed book. That LexiComp site is updated every day. You have a printed book. By the time that publisher prints that book, it's already 2-year-old information. So it's much better to use the website if you can. Books are great. Books are great. But the school is purchasing the website, or the department's purchasing the website access for you, so you don't have to purchase a drug book. Can you use a drug book? Absolutely. But the LexiComp site is something that you can also use in private practice if you need it. So ethical applications is what we're looking at here. The discussion board is open, and that deals with ethical applications. You will have to probably look up chapter 1 or 2, whatever it was at the beginning of the chapter, to talk about some of the instances that are in the in your particular scenario. But with the discussion board, you're just staying within whoever your person is. Okay, so if you're doing Darius, then you just stay with Darius. If you're Lorna and Summer, that is what you're talking about. You're not going into somebody else's discussion board. You're more than welcome to go in and look, but you're not obligated to respond to them. So part of the ethical consideration is also looking at what the consent forms are that the patient has to sign. So those consent forms, we're calling them the super form, are printed or available to be printed in Canvas. Go ahead and print them out, have them in sheet protectors, because each of your patients, your new patients, is going to need to be taking a look at that. And that deals with respect for the patient. The patient is signing that they will respect you as well. And there's also a cheat sheet there where you can have just a short synopsis, a little paragraph on what these forms are. But we want to see the patient with these full forms, because some of them are going to want to look at them. Most of them aren't. You want to make sure that you maintain the communication among all the parties responsible for dental treatment. So that's not only you, okay, and the patient, but it's the doctor. With us, it's the instructor as well. You're attaining knowledge of current standards of care as well as the legal scope of practice. That's something that the school will be teaching you, but as a licensed professional, you are obligated to know what your license allows you to do and what it doesn't allow you to do. How many hygienists can be employed in an office at one time? This was a big thing for a number of years. How many hygienists? A dentist can supervise 2 RDHs at a time, 2 hygienists. So if you had a single practice or a multi-doctor, let's say, office, but only one doctor was in there, there could only be 2 hygienists that day. There could not be a third. Now, they could supervise 15 dental assistants, but there could only be 2 hygienists. That's changed. So now 2 hygienists will be working under the dentist, and then that third hygienist will be practicing under general direction. General direction is something I never thought I'd see in my lifetime, but it's an agreement with all parties, you, the hygienist, the dentist, as well as the patient, that the doctor's not here or the doctor won't be coming in to do your exam today. If there's something that stands out, or if you're not having any issues, we're done. We won't charge you for the exam, or we will reappoint you. So every office is kind of handling that a little bit differently. If you're working under general direction, you must have a conference with your doctor first, and they need to write down in the chart the prescription for what they want you to do. It's not just a standard cleaning. You're going to be doing 1, 2, and 3. And they're signing it because you are working under their license here in Virginia. Are there any questions on that? I know that you've probably been in some interesting scenarios with your offices. So understand, just get a feeling for what that super form is, all right? And some of this is, I will respect you, you will respect me. You're telling us that you'll come to all of your appointments in a timely manner. We will explain everything to you before you have it done. This is your record. If you want copies of anything, we're happy to do that for you. Your information is private. You know, that's the HIPAA. And then the one thing that we as faculty need to hear is the authorization for treatment. Do you remember what that is? That's the biggie. That if there is an exposure between the two of you, you and your patient, you both agree to get a blood test within 24, 48 hours, and you will share the information. And it's at their expense.
Ms. D, we have to have the super form printed, right, on our side?
Yes. Yeah, the patient has to be able to see that in case they want it. So usually when we come for a new patient and there's a medical history check-in, they've got your clinic notebook, or they have those pages out of the notebook on their lap. And then you're going through, oh, and then this is the HIPAA, you know, we will keep your information private. This is your records form, which says that these are your records. You can have copies of anything that you want. But then what we want to hear from the instructor standpoint is that authorization to test, because we are signing the super form, and that super form, when we sign it and the patient signs it, is saying that that patient understands and knows about that authorization to test. We don't want an exposure to happen and then them to say, oh, well, I was never told. Okay, we heard it. We as the faculty heard it. So I don't sign it until I hear you explain that to the patient. All right, so let's get into chapter 22, the dental hygiene diagnosis. Oh my gosh, has this gone under a lot of scrutiny over the years, because dental hygienists are not allowed to diagnose. And that's going to be just really crammed into your brain. Can dental hygienists diagnose?
No.
No. But We can create a dental hygiene diagnosis, and that is expected of us because we are doing the assessment for the doctor. So the doctor is agreeing with us or disagreeing with us. Okay, but we're getting all the assessment together. We are coming up with our impression of what all this assessment data is and what it means. And that is our dental hygiene diagnosis, which differs from the dental diagnosis. So we usually say DH for dental hygiene DX diagnosis. And it's based on the assessment findings. And what we're going to do is identify any additional factors that can influence the planning for our dental hygiene care. Now, our dental hygiene diagnosis deals with what we can manage in the dental chair. Okay, what is our scope of practice and what can we handle? So for assessment findings, we're always writing down what's the chief complaint, and that is part of the template. What is your CC, your chief complaint, or CO, complains of? You're typically seeing hygiene patients. Oh, I'm here for a cleaning. So that's what you're going to have, chief complaint, none. Is anything bothering you today? Do you have any specific concerns today? That's their chief complaint. Oh, I have some sensitivity on this upper right to pressure when I bite down. So that is going to be their chief complaint. Or I'm bleeding when I use dental floss, or my husband complains that I have bad breath. Whatever it is in your discussion, that's your chief complaint. And you're looking at all the various risk factors as well as risk indicators for your patient. So what are the individual risk factors for your patient for periodontal disease? What is in their medical history to help encourage periodontal disease? Do they have high blood pressure? Obesity is now a risk factor for periodontal disease as well as ASA. Do they have diabetes? What's going on with them systemically? What risk factors do they have for dental caries? Your EOIO, after you do your EOIO, before you get it checked on a new patient, you're always doing a caries risk assessment. Are you drinking fluoridated water? What type of snacking do you do? That type of thing. Have you had a cavity within the last 3 years? And you're coming up with an assessment for that. So a teenager might be more at risk for dental caries than for periodontal disease. And that, again, is going to drive your oral health education for your patient. What are the risk factors for oral cancer? Are they smoking? Are they smoking and drinking alcohol? Are they using some sort of other tobacco product that puts them at higher risk? Are they chewing the betel leaf? Because that's part of their culture, that puts them at an increased risk for oral cancer as well. And you're going to be learning more about that as you go through not only pathology, but go through the program here and continuing education, everything else. So you never stop learning about that. So you're looking at the patient's overall health status, and that starts with their physical status. You're bringing them back from the reception area. You're looking at them. Are they doing the, we call it the Tim Conway shuffle, but you don't know who Tim Conway is. Carol Burnett had a variety show years and years ago, and he played a little old man, Tim Conway shuffle. And it's the old person shuffle. They can't pick up their feet. And so they are at a fall risk because their toes get caught on area carpets and those type of things, and they fall. Excuse me, we've talked about tobacco use. There's something called OSCAR, oral systemic capability, autonomy and reality, OSCAR. You need to know what OSCAR stands for. You need to know what each letter stands for. there might be a board question about Oscar and the R in Oscar, which is the reality. And where does that find?
Is that on the PowerPoint? Because I didn't write it down fast enough.
No, it's not on the PowerPoint. OSCAR, it's in the book.
Okay.
I purposely don't put a lot on these slides. I purposely use what the publisher gives me because they are so vague, it drives you to the book. And Wilkins is one of those courses. This is one of those courses where you've got to read the book. There's no getting around it. Now in perio, you know, the slides are more comprehensive. Oral anatomy, the slides were more comprehensive. People have gotten away even in pathology without purchasing a book, because the slides are so comprehensive. We take all this information and throw it together. But this is something where I really need you to be taking a look at the book for, because this is what your boards are going to be. People come back from the boards and say, if you know the Wilkins, you've got it. And Oscar is one of them. Tobacco use, that includes marijuana. If they're smoking it, we want to know. Oral health care literacy level of the patient. Now, we call that the dental IQ. When we had these stamps we used to put on paper charts, there would be a thing for a dental IQ, and we'd grade them A, B, C, D, or F. If they had a high dental IQ and high motivation, they wanted to take care of everything, that would be the A. If they were unaware of what was going on in their mouth and had no interest, then they would have a lower grade. And that's where more education is needed. 22-2 is Oscar. Thank you. And what's the patient's self-care ability? They're doing the Tim Conway shuffle coming back, and they've got arthritis and they can barely sign their name. Are they going to be able to utilize all these wonderful gadgets you want to give them? Can they floss? You know, they've got arthritis, where is it? Is it in your hip, or is it in your hands? Is it in your neck? Do I need to alter how I am laying you down or can't lay you down? Self-care ability is not only physical, but their mental capability as well. Is this patient needing somebody else to take control of things? So what would be patient's self-care ability with dealing with age? For example, you've got a 3-year-old in the chair. They're not going to be able to brush their teeth adequately. So that will still take a parent to follow up. Now, does a 3-year-old get a toothbrush and gets to chew on that toothbrush? Oh, yes. But mom or dad or a caregiver has to follow up. So no matter what the age is of your patient or client, you're always looking at that self-care ability. And then we're dealing with various risk levels here, the periodontal diagnosis and risk level. So planning for the number and length of appointments in the treatment sequence are going to be affected by both the dental and dental hygiene periodontal diagnosis. So who has gotten beyond the treatment plan yet last week? Has anybody signed the treatment plan?
I think I got all the way up into the cow.
Oh, you were almost ready. Okay. Yeah, the treatment plan is formulated before the instructor comes in. You've done your periodontal charting, you've done all of that, and then you guesstimate the periodontal status and you make your treatment plan. Do you need, based on the periodontal status and the amount of calculus difficulty level, do you need 1, 2, 3, 4, 5, 8 appointments? Do they need topical anesthetic or local anesthetic? How much scaling? What are you going to need to use the ultrasonic? Is it going to be hand scaling only? Any other treatment? Do they need to come back for a re-evaluation? And that depends on the classification of the periodontal status. So we've got, this is the ADA status, and this is going out of fashion because we're going to be using the AAP classification, which is the staging and the grading, but you're going to be learning both. I believe the second year students, the graduating class, rumor has it, is going to be the last class that actually is going to be having this on the boards. But anybody who's been out in private practice for any length of time is going to be doing the staging of 1, 2, 3, or 4. 1 is slight, 2 is moderate, 3 and 4 is advanced. Okay, and then the parameters of care is also being taken into consideration. Who remembers what the parameter of care is? What's the purpose of that? The purpose of that is to let you know, the office know, when do you need to refer this patient to a specialist? Is this patient under the category that you can treat in general practice, or is it beyond your scope and they need to see a specialist, a periodontist or an endodontist or whatever that specialist is? That parameters of care is there to help decrease the amount of litigation of malpractice or unsupervised care or supervised neglect. You have somebody who doesn't allow you to take radiographs year after year after year. That is supervised neglect if something goes unseen because you don't have a radiograph. If somebody needs scaling, root planing, or referral to a periodontist, and they refuse the treatment by you in your general office or referral and you continue to see them, that is supervised neglect, whether they give you permission or not. I just want a cleaning. Just clean them. And we are, we're faced with that every day. So that's the parameters of care. Dental caries risk levels. This is chapter 25 and chapter 47. We're going to be getting into more detail with that, but you're going over, this is the Canberra, the caries risk assessment, restorative treatment, what is needed. Have they had any recently? And was it new decay or old decay? I'm old. I haven't had a cavity since I was, I think, 8 years old or something like that, but I have fillings in my mouth. My fillings are going to break down. I still have amalgams from when they didn't have sealants when I was younger. So they put these very shallow amalgams in because they didn't have composites either. Instead of sealants, okay, as kind of a treatment plan, but they're breaking down. So I might need some restorative work. Is that a cavity? No, it's just something old and decrepit that needs to be replacing. So I wouldn't consider that to be a high caries risk for me. I'm a dental hygienist. I've got good oral hygiene. Ideally, I would be seeing a dentist regularly, but I have not seen a dentist in years because I don't have dental insurance. And the only people that have cleaned my teeth have been students. And even with that, it is going to, it's few and far between. So the dental hygiene diagnosis, DHDX, okay, you're looking at the assessment and then you've got these diagnostic statements that you're making. You're not saying that the patient has gingivitis. That's a diagnosis. You're stating that the patient has, okay, rolled gingival margins, they're edematous and friable, they bleed easily, as evidenced by the biofilm at the cervical area. Your clinical impression is gingivitis, and that's where we get around the diagnosis. You'll have a clinical impression. What does it look like? We're describing something. We're describing a petechiae adjacent to the distobuccal cusp of number 14. Clinical impression, cheek bite. Patient states, bit their cheek. Patient states, burned their palate. Your clinical impression, you have a depressed lesion that is whitish gray on the inside and bordered in red on the outside. It's 3 millimeters by 3 millimeters, present for about 3 days. Adjacent to on the labial mucosa of number 22. Patient states they bit their lip. What is the clinical impression? Would be an aphthous ulcer, canker sore. We wouldn't use canker sore in the in our notes. We'd say aphthous, but then everybody goes, aha, I know exactly what it looks like. We're not saying it's an aphthous ulcer. We're saying it looks like an aphthous ulcer. So can you see the difference between the dental hygiene diagnosis? The dentist is going to come in and say, that's an aphthous ulcer. But we have a clinical impression. Clinical impression, amalgam tattoo. Might be Kaposi sarcoma. We don't know, but it sure does look like a an amalgam tattoo. All right, then we've got our prognosis. What is the likelihood of something happening? Again, your prognosis is going to be for caries. Your prognosis is going to be for perio, and they have perio and oral hygiene risk assessments that you can download also. The Sonicare people, the Philips Sonicare has periodontal risk assessment as well as oral cancer risk assessment. There are companies that you can purchase these risk assessments for, which we were using for a couple of years, but it was so time consuming. Our poor students never got to cleaning their teeth because it would take 3 appointments just to get through all of this stuff. But a risk assessment, are they using smokeless tobacco? Are they using a hookah? I mean, if they're only using a hookah, even if it's once a month, they're getting so much of that nicotine in their mouth that they might as well be smoking every day. You know, that risk kind of evens out. So the more you learn about what your patients are doing, the more you can educate them. Individual tooth prognosis versus overall prognosis. I have a huge filling on tooth number 14. I've got an MODBL amalgam. That's every tooth surface, okay? You only have 6 surfaces of the teeth, but I've got this huge amalgam. We would call them amalgam crowns years ago. What is that tooth's prognosis? That tooth's prognosis is poor, because you can guarantee I'm going to break that tooth one of these days. We don't know when, but the prognosis is poor. You know I'm going to end up needing a crown. So the dentists that call themselves conservative dentists would say, this tooth is going to break. Let's not have it risk that and have it break below the gum line area. Let's go ahead and put a crown on that tooth now to protect it. Because if it breaks below the gum line area, which we can't predict, then you will need a root canal, you'll need crown lengthening, you'll need, or you'll need to have the tooth extracted and you'll need an implant. So that's an individual tooth prognosis versus the overall prognosis is what we're doing with caries risk as well as your perio. So we're putting it all together. And it takes a long, long time to do this. as far as chair side time. And again, we're documenting everything. If it's not written down, we haven't done it. So our template that's over after a template, and then you've got your documentation on the right-hand side of Dentrix, it will tell you when you need to sign it and when the instructor needs to come. And that's what part of this is all about when you're working on each other, is just to try and get more familiar with the Dentrix program and when do you need your special signatures. So if you're using paper charts, it must be in ink. Everything must be date and signed. You have to use standardized abbreviations, and Canvas, I posted the American Dental Association accepted abbreviations. There are some medical abbreviations too. C with a line over it for with, S with a line over it is without, but W-O for without is more, plus you can put that in the computer. Okay, everybody has to be able to know what you mean. And that's the standardized abbreviations. Now you could have standardized abbreviations for your office as well, but there needs to be some sort of a template somewhere that shows a temp coming in what the abbreviations mean. So you sign stuff, we sign stuff after you sign it. After the instructor signs it, that page goes gray. We cannot make any other changes to it. Now you date and sign it. You can still go in, the instructor comes in and we're going, well, I'd like it, you know, add this, take that away, whatever. And then you can tweak what you've written down. And then once the instructor signs it, it is permanent record. To make any other changes, we have to go in and make an addendum. And that goes to the bottom of the note, and it's just whatever changes you want to make. So that, unlike the paper records, that means we can't go in and write something in the margin because we forgot. Okay, it's all in sequential, dated and timed. So are there any changes? And I'm sorry, any questions? All right, I've been yakking for almost an hour. So what we're going to do is take a real short break, and I'm going to bring up the next PowerPoint. So let's take a 5-minute break and we'll be back.
Misty,
Yeah.
would you say this this ADA symbols and acronym PDF, is that something that we have to know to put into Dentrix, or does it automatically come into Dentrix?
It does not automatically come into Dentrix.
Okay, so it's like 52 pages, but would you recommend that I print them?
No, no, just know where they are.
Okay.
And you can always spell things out.
Okay.
When in doubt, spell it out. Now, I haven't, I mean, I don't know how to spell petechiae. I know there's an H in there.
Same.
and in every vowel. I'm trying to figure out what I'm doing here.